Okay, I think people will start to trickle in, but to maintain our time sequences, I think we should move forward. As you can tell, I'm not Francois Lemereux, who's supposed to be moderating this. I was asked to pinch hit. And so my name's Christopher O'Brien. I'm a nuclear medicine doc in Ontario, Brantford, Ontario, and I've been working about 28 years in the field. And so what I'd like to do now is get our second session going on dealing with the heart. And we have some very interesting speakers coming up from around the world, which is a good thing to see, local, international, and from the US. So this is going to be a fun session. Our first speaker is Dr. Pryor, and he is currently the president of the Swiss Society of Nuclear Medicine. And he's also running for the presidents of the World Federation of Nuclear Medicine and Biology. And as you know, one of our own, Dr. Jean-Luc Urbain, has been there, so it's good to see continuity going forward. Dr. Pryor is at the Lausanne University Hospital and is the director, professor, and head of the nuclear medicine and molecular imaging program there. And he's going to talk to us about myocardial blood flow, quantitation of the heart, very important aspects of our next step forward, I guess you can call it, for cardiac imaging. So without further ado, Dr. Pryor, the podium is yours.
Thank you very much for the nice introduction, and thank you for the organizer for the invitation. Without further ado, I'm going to speak about PET-CT quantification of myocardial blood flow with rubidium. I have no conflict of interest. And as non-invasive diagnostic imaging of ischemia is well known for many years, there is an increase in this diagram where you can see that the perfusion abnormality are the first steps that are seen in this cascade that leads to angina pectoris. The best thing to image is rubidium, cardiac PET-CT, and cardiac MRI, but also as you have more depth into trouble, you can image that with echo and ECG. What is known is that the net extraction of myocardial blood flow is non-linear, but using radio pharmaceutical models, you can backtrack and get absolute myocardial blood flow, which I'm going to show you. Rubidium is an analog of potassium, and then you can see it as the effect of NAK ATPase. Kinetic modeling allows you to increase the myocardial contrast and see better small abnormality in flow, as you can see here, going from the net uptake to the uptake rate, and then the flow once you apply pharmacokinetics to the images. It is a major quantification, and it has been shown with rubidium that you can get the same perfusion abnormalities and flows that you would do with ammonia or O15 water, and it has a good reproducibility with excellent agreement between global and regional myocardial blood flow. There are some software that are using this model, and if you use the LORTI model that has been developed in Ottawa, then according to several different software, you get the same flow. What do we measure when we quantitate myocardial blood flow? We know that it's an integrated measurement of the epicardial, the large conductance vessels, and also taking into account the resistance vessel. You can see here that there is a total number of small capillary vessels that are being measured by rubidium, but that are not seen at all on the coronary angiography. The clinical protocol are very short. You can have the patient coming in the department and leaving 1 hour later, fully dressed, and it's only about 24-25 minutes in the machine. We have been, with the latest silicon photomultiplier PET, been able to decrease the acquisition injected activity with only 5 megabecquerel per kilogram, and it's a least mode dynamic acquisition that allows you to also measure left ventricular ejection fraction. The scan can be also very low in radiation burden, and actually we do per scan less than 1 millisievert for a 70 kilogram patient. Digital silicon photomultiplier have been allowing us to get further performance enhancement. When we received this machine as a second worldwide installation in 2018, we were amazed to see the image quality and the benefit of the time of flight. You can see here with our first patient that could have been looking like melanoma, although it was a leiomyosarcoma, and you can see all the fine details of the smallest lesions. This applies also to rubidium PET, and you can see that it is a high quality. We don't see what we used to see and say that rubidium scan could look like a good SPECT, but here it's much better than what you can get with SPECT. We were also able to decrease, and here you have a comparative on the older machine, 500 picosecond time of flight PET on the left, and on the right you have with only 5 megabecquerel per kilogram, so half of the injected activity, a very nice image quality with 214 picosecond time of flight PET. I will come back later on the effect of the time of flight, and you will see that in the future we may even get better images. You can see here that when we looked at the comparison of these two modalities, the 5 megabecquerel 214 picosecond had a much smaller standard deviation for a uniform myocardial perfusion, so being able to measure much more precisely the myocardial flow reserve. So with also significantly smaller standard deviation, improving image quality. It's good image quality for all patient sizes. Here you have a comparison, and it's in scale 180 kilogram patient and a 11 kilogram patient. You can see here that image quality is quite good, even in the largest patient with 900 megabecquerel. You get a decent image quality, and also in the small child with only 150 megabecquerel, you get a very nice imaging in this small patient with cardiac failure after transposition of the greater artery. It is quite interesting because we can always take something out of failures. This is something we did wrong, and I can show you that we had injected the wrong activity in this patient. We just were able to change the injected activity minimum amount on our infuser, which actually went from 370 megabecquerel to 37 megabecquerel. And our techs, they didn't see the difference. And so this is, we learned that with only 1 millicurie, so 37 megabecquerel, you could do images, which is actually only 0.1 millisievert for a rest and stress image. It's not the best image quality, but I've seen SPECT images that were much worse than this. We know that digital PET and conventional PET may have different activity, and there is always danger of having too much activity in a digital PET. So this is an interesting study from the Netherlands, where they compared basically both types of imaging, and they looked at the dynamic range and dead time factor for image non-uniformity. You can see here that the measured activity goes much higher with the digital PET as compared to two types of conventional PET. And the maximal activity on one PET was only 350 megabecquerel, on the second PET was 700, and for the digital PET, it was much higher. So we can have a lower digital PET activity here, and we can see that it has actually a much better bias and dead time. And if we run with not too much activity, it provides much better correction possibility for bias and dead time. You can see here that we computed on our PET, on our digital PET with a phantom, with actually Rob de Camp, who came to Lausanne to do these measurements, that we could put a maximal activity of 12 megabecquerel per kilogram with a prompt of count rate up to 12 mega count per second. This would correspond to a patient with 130 kilogram and 6 to 8 megabecquerel per kilogram, which we don't inject so far. So it's quite efficient. It's quite good at measuring absolute quantification, even in large patients, necessarily with high activity. Today, the clinical indication are multi-vessel coronary artery disease. We know that balanced 3-vessel disease is especially difficult also to measure, but with quantification, it's much easier to detect. And it could be also subclinical coronary artery disease when we know that decreased myocardial flow reserve is initiation of risk-reducing medical therapy trigger. So this is also quite good for this. And it has a more accurate assessment of ischemic burden in the patient that do have intermediate coronary artery disease probability. We know that it can reclassify, for instance, these intermediate patient population on the pre-coronary flow reserve measurement risk, and it risk classify into 51% of this intermediate risk is either classified into high or lower risk. So it is quite efficient in this study by Murty in 2011, and this is what PET can add to SPECT, for instance. We had a small prognostic study, and so we can see here, even in patients that do not have any abnormality of flow, it's a right picture here, that you can classify patient according to coronary artery disease MACE risk, and patient with the lowest tertile have many more events than patients in the highest tertile. So you get a prognostic value even in the absence of ischemia. Here, for instance, a practical example of the helpful measurement of quantification. If you just look at this semi-quantitative reading, you would see that maybe you would be in front of a one-vessel disease. Although if you do quantify, you can see that the rest and the stress myocardial blood flow are quite the same, with a very small increase in myocardial flow reserve. And in this patient, basically, it was the presence of a 3-vessel disease. So he would have been masked, and we would have done a wrong diagnosis if we were only based on the semi-quantitative readout in this patient. We know that the myocardial flow capacity is a nice way of showing the results. On the horizontal axis, you have the stress flow. On the vertical axis, you have the coronary flow reserve. And based on the quadrant, you can have either a totally normal flow, or you can get into reduced coronary flow capacity with higher coronary event rate. We do know that this myocardial flow capacity predict the patients with the highest coronary vascular risk. And we know also that if patients are operated and either by PCI or CABG, if they have a severely reduced myocardial flow capacity, we can significantly reduce, as you can see on the right image, the risk of cumulative hazard for death. We know also that PET is really helpful in guiding revascularization. You get significant change basically after having a revascularization, either in absolute myocardial blood flow or in percentage change. If you do have more than 10% perfusion abnormality, which is the left side here of the diagram, and more than 10% of myocardial flow capacity that would be severely reduced. You also get a significant reduction if you have less than 10% perfusion abnormality, but also more than 10% of the myocardial flow capacity that are severely reduced. You do not get any advantages of revascularization if patients do not have abnormality or abnormal myocardial flow capacity, as shown on the right two bar graphs of this picture. So in summary, quantitative cardiac PET is a really first absolutely clinical nuclear medicine quantification that we do. We apply pharmacodynamics in real life, and we can do it for most patients. We do get a very nice image quality and sensitivity and specificity. We increase because of the myocardial flow capacity, our diagnostic confidence, and we can do all that with a less than 1 millisievert radiation dose, which is quite excellent. The myocardial blood flow quantification and flow reserve have added prognostic value for also deciding if patient has to undergo therapy, revascularization. It's a very powerful, non-invasive way for detecting coronary artery disease, but also for guiding clinical decision between medical and invasive therapy. The hemodynamic assessment of coronary lesions can be also correlated in choricity and angiography. We do use that every day in the clinics, and doing the first FDG uptake, we have time to perform 2 rubidium in the time of flight that was introduced. The first generation were about half nanosecond, so 500 picosecond, then it reduced to 300 and even 200 now. And we would like to introduce a challenge and to push the industry to go forward and to make a quantum leap forward towards a 10 picosecond. And we hope that it would be basically reached in 2025 or 2030, but it's still a challenge. We try to push that. What would a 10 picosecond PET would bring as advantages? It would allow the direct positron emission imaging with a 1.5 millimeter resolution along the line of response. So this would be really also increasing what we do now know as sensitivity. It would be a factor of 16, which would allow us to reduce the injected activity by a factor of more than 200. It would also maybe allow you to image a lot of patients with only 1 radiopharmaceutical dose, and it would open totally new application. So with a group of physicists, we launched this 10 picosecond time of flight challenge. This is what you would look as a non-time of flight filter by projection. You know that OSEM is better, and it looks a bit what we have now. 10 picosecond time of flight PET would look this way. So those are simulation, and the OSEM would look like this. And this is not a morphological slice, it would be functional slice. So this would be really highest resolution of functional imaging we have. We developed a paper, 22 authors, 64 pages, showing the roadmap for the 10 picosecond time of flight PET challenge. And it would really open new medical application, for instance, better quantification. It would allow investigating new populations. That would be quite interesting. Even fetal imaging could be done. And as you have seen also with the total body PET, we could look at 200 times dose reduction, which would be the equivalent of a 0.03 millisieverts, so a 1 week of natural radiation equivalent. And it would use really longer imaging time for any tracers. That would be also very much simpler design, because we would not need to go around the patient. It could be 2 plates, a bit like Terry Jones presented 20 years ago. And it would allow new fetal and psychiatric disease application. So we created this challenge, and we hope to be able to launch it. It would be a €1 million prize for the first group that could reach these milestones. And it's a bit like going to the moon. Going to the moon did not bring us, besides a few rocks from the moon, but all the technology that had to be developed to go to the moon are still something that we benefit today in everyday's life. So we would like to push physicists and crystal technology and electronic technology to be able to reach this challenge. Most major player in the molecular imaging field are endorsing this challenge, and there have been also scientists endorsing this challenge. And if you do, you can also just write me an email and you can endorse this challenge too. So in summary, this 10 picosecond time of flight PET challenge would be allowing this direct positron imaging, and also trying to impact societal challenges, such as going for screening neurodegenerative or psychiatric disease, and looking at all infectious disease. And we have seen lately how important are infectious disease in the population, and also going through all spectrum of the life, from the prenatal to the geriatric life period. With this, I would like to thank you for your attention. And of course, nuclear cardiology would also benefit from these. For instance, we probably could be able to look at endocardial ischemia and differentiate it from endocardial from epicardial, and get much precise thresholds and low activity in our patients. With this, let me thank you for your attention.